Dr. Smiti Jain, and the topic is start early, lower, fewer, and better.
I'm Dr. Smiti Jain. Welcome everybody. And this is something that I want to discuss, that all therapies, whenever we have glaucoma, let us start early, let us lower the pressure with fewer drugs for a better control and a better patient experience. It's not going. Yeah, so glaucoma is the second leading cause of blindness in both developing and the developed countries. The risk factors for blindness are a higher IOP, worse visual field status at presentation, and an older age group. The goals of glaucoma treatment, we all know, is to maintain patients' visual function at a sustainable cost. Visual field loss definitely decreases the quality of life and causes a lot of problems in patients as the glaucoma advances. Now, if we look at this chart, the normal visual decay and the clinical glaucoma, which is controlled, the decay, the mean rate of progression is almost similar. So if we treat a glaucoma well, then we actually prevent the decline in the vision. So as presented earlier, ocular hypertension, we all know, where the pressure is really high, but there are no other field changes or optic nerve changes. Now, we have to remember, if the pressure is above 30, we need to treat these cases. We always have that risk calculator. We calculate the risk and of course put them on treatment. If we have a lower CCT, higher cup disc ratio, so we just follow this and treat them early. Normal tension glaucoma is another one where the pressures are not high and we can miss the glaucoma. So the crux lies in careful examination of the optic nerve and a high suspicion rate. The visual field defects will be closer to fixation, and these are the cases where patient can have progression very fast. So what really to focus on in NTG is, anemias, arrhythmias, other things, the sleep apnea, treat those as well. A dip in the nocturnal blood pressure also needs to be controlled. Important signs to look for is the disc bleeders. And we need to get the pressures down by at least 30% in these cases. Now the rate of visual field progression can vary between different patients, and that is how we should start the therapy and upgrade the treatment. So A is the normal person with a normal visual decline. B is a patient who has presented late. I mean, his age is more and there is a decline, but it is moderate. So we can control adequately with maybe a single drug. C is the patient with a similar kind of a visual field, but we have picked it up early. The patient is younger. We need to be more aggressive here so that the visual field does not deteriorate. And we need to be continuously monitoring. At least 6 visual fields in the first 2 years will give us the rate of progression. E chart shows us that there is a fast visual deterioration here. So here we need to be very aggressive, maybe go in for a surgery or medication. So earlier and lower, what I mean by this is that detection of an early visual field progression may help us to prevent the further loss. We can step up the treatment. Now, something very important is that we have to keep in mind whenever we are treating the patients is the target IOP. Now, what is a target IOP is just a range where we feel that the progression will not happen. Supposing we encounter a patient who has a pressure in 30s. So let's start with at least a 35% reduction in that and then go forward. We have to keep assessing these patients regularly and keep adjusting the target pressure accordingly. If there is progression on repeat examinations, then we decrease the target pressure further. So a staggered percentage reduction system like 30, 40 or 50% can be recommended for mild, moderate and severe glaucoma. So the target pressure depends on how much is the pressure, what are the additional risk factors, more importantly the rate of progression. This is a chart where we can approximately, we know as we have advanced glaucomas, the target pressure goes down and further down. So the initial treatment usually is medical treatment what we start, and prostaglandin analogs are usually preferred as the first choice because of high systemic safety, highest reduction in pressure, a good 24 hours control, and 1 drop a day of a prescription. We have too many medications these days. We have a battery of medical therapy. We also have fixed dose combinations. So we always need to start with a single drug in most cases. If you really feel the pressures are high, then you can go for a fixed dose combination initially. Now the meta-analysis of medical treatment also shows bimatoprost is the winner here. It has a marginal benefit as compared to latanoprost and travoprost. Bimatoprost 0.03% used to show us a lot of hyperemia and ocular surface disorders, but with the bimatoprost 0.01%, these things are better controlled. It is almost comparable with latanoprost. Now early progression within the target IOP, even if you have set the target IOP, if there is progression, get the pressure down again. So in that case, either you can switch the drug. Supposing your patient is on prostaglandin analog, you can switch the treatment and see between the prostaglandin analog, the latanoprost to travoprost or to bimatoprost, before you step up therapy and add another drug. Bimatoprost plus timolol is a fixed dose combination, and both these drugs are synergistic in action and achieve a good control of IOP. By mixing these two drugs, also the adverse effects have found to be decreased. The hyperemia comes down, the burning sensations are less, foreign body, whatever we have encountered more with bimatoprost. Somehow after adding the timolol, the patient is more tolerant to this drug. Bimatoprost and timolol again have a small advantage, again latanoprost timolol combination as well as the travoprost timolol combination. Why efficacy after switching? Most frequent reasons for switching to bimatoprost timolol fixed dose combinations were insufficient IOP lowering on prior therapy, progression of glaucoma related damage, unacceptable tolerability of prior therapy, and lack of compliance. With a single dosing, usually patients are better compliant, there will be less side effects, and it has a lot of advantage. The conclusion for today is, once a patient is diagnosed of glaucoma, characterizing a risk profile is useful to plan and individualize the treatment strategy. Main factors are the visual field damage and IOP. Target pressure needs to be set. Patients shows a meaningful risk profile may benefit from an earlier and lower IOP reduction with medical treatment. Highest efficacy is achieved with prostaglandin analogs. Along them, bimatoprost is the most efficacious one while preserving a good tolerability profile. At follow-up, early and fast progressors deserve additional, earlier and stronger intervention with fewer and better treatments. These patients may benefit from a fixed dose combination, and that's about it. Thank you.